friends. Thank you for listening to this episode of Pound This. If you are a Pound This fan or if any episode of Pound This has ever benefited you, I would greatly appreciate if you could share the love and join my Patreon. Join the Pound Pack and check out my second podcast, Pound Town. Yeah. You can only access Pound Town, also other offers, when you are a Patreon member, and you can go to patreon.com/PoundTownPodcast. You can find the link in the show notes, and by supporting my Patreon, you are supporting moi, Amanda Valentine, and this podcast, so I can make pound this even better. So thank you so much for listening, and please consider being a Patreon member.
You're the guy people call when they need a helping hand, moving furniture, unloading a truck. But lately, your shoulder's been acting up, and you're the one who's calling for help. And that's the moment you realize you can no longer shoulder the load.
The Joint and Spine Center is Cincinnati's leading destination for orthopedic care, with a range of surgical and non-surgical treatments. So when a moment has the power to change the rest of your life, go to the one place with the power to change it for the better, the Christ Hospital Health Network. This changes everything.
The Pound This podcast is brought to you by the Christ Hospital Health Network. This is the Pound This podcast, episode 703, Foot and Ankle Mobility, Plantar Fasciitis, Bunions, and more, with Dr. Robert Kulwin.
I want to lose weight, but I don't know how to get started.
What should I meal prep every week?
How do I get those sweet booty gains?
Inspiration for your healthy lifestyle. The Pound This podcast with Amanda Valentine.
Thank you so much for listening to the Pound This podcast. I am Amanda Valentine. Joining me from the Christ Hospital is Dr. Robert Kulwin. How are you?
Oh, I'm doing great. How are you doing?
I'm doing good. I'm excited to talk all about feet. Such a popular topic on the internet.
Yeah, no, it seems like everybody always comes in Googling stuff and everyone's feet always hurt and ends up invariably any social gathering. Oh, hey, by the way,
yeah,
or something like that.
Well, and that's thing. It's funny thing. I just saw a TikTok about the correct ways to massage a foot, and then just another kind of way to think about it of we're on our feet all day. Our entire body weight is on our feet. And then we tend to just cram our feet into uncomfortable shoes or not even take good care of our feet, which I feel leads to a lot of problems. I'm sure with what you do, you see a lot of issues that are caused by just a bad day-to-day life of things of how we kind of brutalize our own feet.
Oh, absolutely. It's kind of like the old saying is, spend your money on the things that you're going to use the most. And you spend 8 hours a night in your bed, so get a good mattress. You spend the other 16 hours a day in your shoes, so get some good shoes.
Exactly. So before I kind of go into a barrage of questions about ankles and feet and all that stuff, so tell me about you. Are you from Cincinnati? Where did you go to school? Tell me what made you want to be a doctor specializing in ankles and feet and all of the above.
Yeah, I'm a Cincinnati boy, born and raised. Grew up kind of Hyde Park and Anderson. I went to high school here. And then I went to Harvard for college and then University of Chicago for medical school, and then did my residency training at IU in Indiana, and then finished off with a foot and ankle and trauma fellowship at Illinois Bone and Joint Institute in Chicago. And in terms of being an orthopedic surgeon, it's kind of the same old story, kind of aspiring jock manages to hurt himself and decides to go into, fixing other aspiring jocks. And foot and ankle was a bit of a curveball for me, actually. I thought I would do sports or something like that. But I realized that within foot and ankle, I get to do all parts of orthopedics. So I do joint replacements, I do fusions, I do deformity. I operate on athletes for kind of, cartilage lesions and instability in their ankle, trauma, all that stuff. I get to do all parts of orthopedics, but still be a specialist where I'm able to provide kind of the top care in something where I'm high volume. This is what I do. This is what I'm an expert in.
That's awesome. So would you say that in general, most of the population has some sort of limited mobility or issues when it comes to feet and ankle?
I think that a huge portion of problems that gives people foot pain and sometimes even ankle pain, and the plantar fasciitis stuff, the kind of arthritis in your foot, even the Achilles stuff in the back of your heel, a ton of that spurs from being tight and having what we call tight heel cords. So kind of your Achilles tendon is tight because when we walk, we have to roll over our foot. And it puts a lot of stress through that if we're tight in the back. So I think I probably end up having 80% of my patients do stretches for their Achilles tendons, and almost every problem can get better with just that even.
So what kind of stretches do you recommend?
So the two best ones for that are to kind of lean up against a wall and kind of push your foot back so you're really feeling that nice stretch. And the other one, and the one that has kind of the best evidence, to be honest, and has been studied, is to kind of put your toes on a stair and just hang your heels down and just hold that for 3 to 4 minutes at a time. Kind of get your cell phone out, watch a YouTube video, read an article, and just really let that stretch sink in. And if you kind of do that a couple times a day and hold that for, combined 8 to 10 minutes, that's been shown to really be the best thing to get that stretch going.
So is that something that just generally people should just be doing on the regular anyway before they get to a point of pain? Is that just a good stretch to incorporate into everyday life?
Yeah, I mean, I think that stretching is something that in athletics in general is a lot of times overlooked. And in, not just the foot and ankle, but in general, a real reason people get injured is they don't kind of stretch and take care of themselves. But I kind of consider it doing regular maintenance on your car. You got to do your heel core stretches. And it's just, even I've ended up doing them over time, as I find that it just, you don't get that kind of tightness where, you're hobbling down the stairs the first thing in the morning, even if you're not getting pain from it.
Definitely. So I know that plantar fasciitis is such a topic that I get asked about a lot. And then you can kind of see all the race medals behind me of doing lots of running and all of that stuff too, where I've dealt with my fair share of pain. So at what point, first off, what is plantar fasciitis?
Yeah. So plantar fasciitis is, you have to think your foot has an arch, but I would say, think of it more like a bow, as in a bow and arrow. And the arch of your foot is the bow, and your plantar fasciitis is the bowstring. Your plantar fascia is the bowstring. And what can happen, and especially when you're tight in those heel cords in the back, is you put stretch on that arch, and the plantar fascia just kind of tugs on your heel where it hurts as you flex to the middle of your foot. So that's what plantar fasciitis is chronic irritation of that kind of supporting bowstring, just kind of pulling on that bone over time.
So at what point, could you just self-diagnose it yourself at that of hey, I kind of think that's what this is, or do you go to a doctor at that point?
I think that a lot of patients, this is one of those things where most of them frequently do self-diagnose. There's definitely other things that can be. The biggest kind of thing that you don't want to mistake it for is you can have a stress fracture of your heel bone. But there's usually pretty significant differences in that. And so the plantar fasciitis, usually you get that pain first thing in the morning. Those first few steps out of bed are just miserable. Or if you're sitting down for a while and then you get up, you're oof, and you're hobbling for a while, but it usually gets better, right? So it's pain that gets better with activity and not worse. If you have pain that's not first thing in the morning, but it's actually getting worse when you're taking steps, or if you kind of take a hard step down and that really hurts, that's when you need to worry about something else. But I think a lot of patients who come to with plantar fasciitis are yeah, doc, I think I've got plantar fasciitis. And I do an exam and I'm yeah, you've got plantar fasciitis.
So what are some solutions for that?
So there's a ton of stuff that you can do. And I kind of have my own way of going about it in terms of I start with, the easiest, least annoying, least invasive things and see how that works and then progress upwards. If you Google it, you're going to find 10 million different orthotics and straps and shoes and pads. And the reason is I think that most of these things do work. But what they do is they just kind of mitigate your symptoms. If you don't get your stretch and your flexibility back, you're not going to really cure the underlying problem. The upside is that plantar fasciitis is very frustrating because it just lasts forever, but vast majority of people will go away within a year, 95% of people.
So is that something that would be necessary to come see you at the hospital and talk about, or something you can just kind of figure out on your own?
I think I'm always happy to see it because I think that it's easy to it's better to have a regimented way of going forward. And most of the people I see have tried something, right? They've tried some stretches, they've tried some Advil or, some gel heel cups or orthotics, and they still don't get better. And it's really a combination of things that I find that works. And so I think that, I think it's reasonable to try some things on your own. And if it's not getting better, then I would definitely come and see me or come and see another, good foot and ankle practitioner because, we see it so often. We get a feeling for, sorting through the wheat from the chaff of what really tends to work and what doesn't.
So what is that when it's helpful to roll your foot on a tennis ball, lacrosse ball, or is that for something else?
So that can absolutely be helpful. And sometimes that can help stretch out that fascia a little bit and kind of take some tension off of it. I actually don't always have people do that. I kind of start really simply with heel cord stretches to get nice and stretched out. The thing that works really well, but that everyone hates doing, is something called night splints. So when you sleep at night, regardless of what position you sleep in, you sleep with your toes pointed down. And you get really tight in the back of your heel. And that's why those first few steps in the morning are so bad. And moreover, when you're trying to get more flexibility so you can bring your kind of feet and toes more towards your head, you're fighting an uphill battle because you're fighting against that contracting down all night. So those are kind of the two early mainstays that I really feel help solve the problem. The other things that we do are more for symptoms. So I'll have people take anti-inflammatories kind of around the clock for a couple of weeks and then back off of them, some gel heel cups really to start. And then that's pretty much what I do to start with for the first 4 to 6 weeks and see how things go. And then if it doesn't get better after that, then we kind of change it up a little bit. Sometimes I'll lock them down in a boot for a while. The boots work really well, but they make people miserable because it makes your knee hurt or your hip hurt or your back hurt. So we kind of try the stuff that's less obnoxious first. And then we say, okay, you really need the boot. Because then when the boot makes your other knee hurt or something like that, you're like, well, I know I've kind of proven that I need this. And then I'll also do an arch support orthotic as my second line. Not because I think it really supports the arch all that much, but it kind of acts more as like a damper. So if you know, the people will put those dampers on tennis strings or they'll put clips on a guitar, it kind of just helps take that tension off when that plantar fascia is trying to tug on the heel. It kind of takes some of that pressure off and can be helpful.
So are any of those inserts just useful as almost kind of like preventative of just to kind of have that so you don't end up having this problem?
I don't know that they necessarily prevent it. I think a number of people have arch pain. I think that the orthotics do help some people. But most people with arch pain, what the real problem is actually with being lack of flexibility in the ankle for the vast majority. Now, of course, you have people that get arthritis and things like that, but even that gets better with more flexibility because you're not putting as much stress through it. Having said that, it's a really useful adjunct. It's cheap. You know, there's a wide variety of over-the-counter orthotics that, you know, that we offer, you know, $35, $40. You don't need, don't start with a $200, $300, $400 pair of custom orthotics. That's the biggest mistake I think people do is they end up getting into custom orthotics right away. Don't get talked into that. I think I have to use custom orthotics 3 times a year because the over-the-shelf ones or the over-the-counter, off-the-shelf ones we have, they've got so many little variations that we can solve a lot of these problems without needing to go there.
So when that's something like, because I know I have inserts in my feet because I have fallen arches, which I want to get into that too. But it's like if I go to like Fleet Feet or a store that kind of does this foot scan and gets you the inserts to put inside of like, you know, your exercise shoes, is that a worthy thing to kind of buy into as almost kind of preventative?
Yeah, I mean, those work really well for some people, but the problem is that they end up really costing a lot of money. I mean, I've literally had patients come in that have paid $1,000 for orthotics, which is insane. And so if we can give you a pair of $35, $40 orthotics and you try them out and they work, great. And in that small percentage of patients that they don't, well, you at least prove that you need to make that investment in custom ones.
Yeah. So for me, you know, kind of doing those scans or whatever, I kind of see that I have like fallen arches, sort of flat feet. So like, what are the causes of that?
Flat feet are not bad feet by any stretch. Okay. So some people have high arches, some people have flatter feet. A lot of people are born that way. They go, yep, my mom's got flat feet. My grandpa's got flat feet. And flat feet, as long as they're not painful, are totally fine. And going back in orthopedics, we used to think that they're bad, the whole you can't go into the army with flat feet kind of stuff. The reality is that a normal foot architecture, a normal foot type, be it a high arch or flat foot, is normal as long as it doesn't cause you pain or dysfunction. And so I don't think that a fallen arch in itself is bad. Now, if you had an arch and then it falls, that can be related to a number of things. It doesn't necessarily you need to do anything about it. The orthotic can be helpful, but it's not going to kind of prevent what goes on. A lot of times if you have an arch and then it falls, it's more related to a tendon problem. Specifically the posterior tibialis tendon, that over time in some people can kind of fail a little bit. And even then, you don't necessarily need to do anything about it, but you can kind of get into the weeds on that one because the real problem is if it does end up causing problems for you, the surgeries to correct that are quite substantial.
Gotcha. So I would love to get your opinion on this. So for me, I am really comfortable in like flat-footed shoes, like love me like flip-flops and Toms. And every physical therapist I've had has acted like I just set their practice on fire by telling them, oh my God, you need arch supports in your shoes. What is your problem, woman? Like, is that the correct response? Or if that's what's comfortable for me, am I cool with wearing my crappy flat shoes?
So I think there's two answers to that. There's, a big thing that I deal with in general is not just my arches are falling, I should support it. That seems like such a logical thing to say, right? Like, oh, if my arch is kind of fallen, I should support it back up. The reality is that our foot is very good at telling us what it doesn't like. So if, and with a lot of injuries, fractures, things like that, what I'll tell patients is listen to your foot. It's going to tell you if you're doing something wrong. So by and large, if it feels good and that's what you're most comfortable in, I mean, that's the goal, right? The goal is for you to feel comfortable. If if you have an arch support and it makes your arch higher, but your foot hurts all the time, don't know that that's really helping anything,
Yeah. Oh, awesome. Yay.
So there you go. Justification. Your therapists are all going to find me and call me.
Right. Well, yeah, because the other shoes, I mean, they make my feet cramp and they hurt and they're uncomfortable. And that's where I've literally summited mountains wearing Toms before. And that's where I'm like, but it's comfortable. Like, and plus I got bunions, which I'm sure is a whole nother topic too, but it's like, they're comfy for me. And that's where I'm like, but I try to cram my feet into more well-supported shoes and it feels like pain and it feels like something's wrong. So, I mean, that answer is helpful for me, but.
So, and again, like, just to bring it back, these are generalizations, right? There are certain times a brace if a flat foot becomes painful, but a flat foot is not something that I treat in most circumstances just because it's painful. Now, there are exceptions where it's very severe and you worry about the ankle joint itself starting to tilt. So, there are definitely times when a flat foot, even if it's not painful, is something that, you may need to get a look at and something like that. But the general rule for this stuff is if you are comfortable, that's probably the right way to go.
Okay. So speaking of shoes, how much of a role does shoes play into our ankle and foot health?
So I think that wearing kind of good, comfortable shoes, whatever they are, is important. I think that if you're not having pain with your shoe wear, you probably don't need to change your shoe wear. But with a lot of people that have pain with their shoe wear, and especially if you've got plantar fasciitis or some arthritis in your foot, there are a number of shoes. There's some more coming out. There's a brand that I recommend a lot. No kickbacks. I could even get them to give me a patient discount. But there's a running shoe called Hoka. Hoka One is the brand. I refuse to say that, so just call them Hokas. And they're a great shoe because they're actually designed for ultra marathon runners. And the shoe itself, the sole doesn't really bend, but it's nice and soft. And it's got a little bit of a roll to the bottom of the shoe. So instead of putting all that stress through your foot, it protects the foot from the stress and it lets your foot roll through the shoe instead of the other way around.
I will say I was recommended to get Hokas by a physical therapist because they stand a lot at work, and it's helped a ton because it was frying out my lower back, and wearing the Hokas has actually helped. And I feel like it feels like walking on marshmallows, which is fun.
Yeah, people absolutely love it. They've got a kind of a thick sole. So I've had occasional patients that are like, they just feel weird. But I think that's only 2 of them. And then one of them tried them again and got used to them and like bought 3 pairs. So, so I think that especially if you're having foot pain, a lot of times I recommend frequently, specifically those shoes can really help with a lot of that stuff.
So how damaging are things like high heels?
So the answer is high heels are, if people want to wear sandals, that's totally fine. High heels, wear them if you want to wear them on like a night out occasionally. Do not make that your daily wear shoe. It causes all sorts of problems. I mean, there's even a condition we call a pump bump, right? Where you get a big bump on the back of your heel. That was from wearing pumps or kind of high heels for long periods of time. Because we just talked about how many of these problems really come from you being tight in the back of your ankle. Or if you're walking around with your ankle pointed all day, it just really exacerbates that tightness and causes, all sorts of problems. The other problem with high heels is they very frequently have what we call a narrow toe box. They kind of come to a point. And it actually is, and they're very old studies, and they're kind of from indigenous populations back in the 50s, but we really don't see very many bunions in people who, in what we call unshod or populations that didn't wear shoes. It's just not something that we saw very often. So it really does imply that most bunions, and there are absolutely something called a congenital bunion, which you're just born with and that's how you are. But most bunions are, as far as we know, at least in a significant portion, related to wearing shoe wear, and in particular, those high heels with like the narrow toes at the top.
Yeah, I have bunions, but I didn't develop them until I started doing a lot of cardio to lose weight. So I was doing a ton of walking, running, hiking. And from that's when I started getting my bunions. And they're uncomfortable. They suck. But I just have to get shoes with a wider toe box. And I don't know what I could have done to prevent those. Was that just so much activity, or was it the shoes I was wearing in those activities?
Probably that has actually a little bit to do with your fallen arch. So some people, and especially people with a flatter foot, they tend to have a floppier foot. Okay. And don't think that the high arch folks get away with not having problems. They get their own different set of stuff. I've got high arches. I'm totally going to get arthritis and perineal tendon issues and all this other stuff. Probably why I'm so busy is that nobody's really safe. But the bunions, when you have kind of a very floppy foot over time, you get what we call hypermobility. And it's actually not down at the toe that this deformity, this problem happens. It's higher up. So if you were to look at your hand, it's not in this joint. Well, I guess this joint here. It's actually up here in the middle of your foot. And so it kind of loosens and spreads out. And it's kind of pop culture says, oh, I got my bunions fixed. And it's kind of not a big deal in a normal kind of course of someone's life. But the reality is that bunions are a rather complex three-dimensional deformity that has been kind of argued for years and years on the best way to treat it.
Yeah, because I've heard before, I've had coworkers in the past that had surgery to correct it. But then I heard that could not be a good choice either, because you're not fixing the root problem of how you're, mobile on your ankles and feet, that they'll just come back again. Is that true?
Yeah. Well, it depends on how you fix it. So I only do 2 surgeries for bunions. And the one, I either do it in a minimally invasive fashion where you get poke holes about this big, and I do it with a little burr, and I do what we call an osteotomy. So I just kind of shift that toe bone over so that it's not prominent. And I fix it with some little screws that are kind of also through poke holes. You can walk on it right away. But I only do that in patients who are older, really having trouble, and aren't able to kind of stay off of this for the 6 weeks that you really need to for most procedures to definitively fix a bunion. Okay. So if you are, and we know that recurrence happens with anything but the other surgery that I do for this, which is called a lapidus. And that's where I fuse the joint that's kind of higher up, that's the source of the deformity. Okay. And that's kind of in the arch area where you fuse that joint together and get rid of the hypermobility. Because otherwise you'll absolutely get recurrence. It's well described in the literature. The question is, do you want to go through a much bigger surgery that is, 6 to 8 weeks off of it? There's definitely some people leaning towards procedures with earlier weight bearing. In my practice, I'm a little bit slow on that. I'd rather you stay off of it for a few more weeks and make sure that we have a good long-term result, because in the scheme of things, another 4 weeks is not the end of the world. But we are kind of moving towards some plating structures and things like that potentially can allow for some earlier weight bearing. So
for people that are very active, people that are listening to this podcast that are exercising a lot and doing the walking or running or lifting and doing so much, movement on their feet, is that something that they should be concerned about? Not only bunions, but then, the plantar fasciitis and the list of problems. Is that something that an active person should work some sort of stretching into their routine so they don't have to think about getting bunion surgery in the future from being on their feet so much?
Well, and I wouldn't say, I think that your bunions may have developed anyways, to be perfectly honest, because, even if you're running and doing that stuff, it's life. You likely had some hypermobility to begin with, and lots of people get bunions that aren't active, right? So I don't think that was necessarily the cause.
Okay.
It probably was just going to happen and you had bad luck, right?
Cool.
Yeah, awesome. Sweet. The other thing I'd say is you can certainly get these things, but the health benefits of being active are just so much bigger than the downfalls of plantar fasciitis, which goes away. And the other thing I'll say about bunions is I have seen so many patients who had bunions on both feet, and 5 years ago or 6 years ago, they had one of the sides done, and they never want the other side done. All right. And it's a good surgery in the right people, but it's surgery, and it can definitely make you worse. There's no problem surgery can't make worse. It's something I say to patients a lot. And so my philosophy of bunions, and I'm rather conservative with these, is if you can find shoes that work for you, you don't have a foot problem, you have a shoe problem. If you've kind of run out of shoe options, you really can't find anything that's comfortable, you've tried going to like a shoe repair guy or a cobbler or having them kind of punch out some more room in your shoes, then you have a foot problem. That's when I recommend bunion surgery, is if you really just can't find any shoes that work for you and you're miserable, that's when it's a good idea to get that bunion taken care of.
So what kind of pain in your foot or ankle or any of that is at a point where you're like, okay, this isn't something I can stretch through, I can get new shoes through, I can get inserts through, I need to go and I need to see Dr. Kulwin? Well,
I mean, first of all, I'd come see me before you get to all that stuff.
Okay.
I'm trying to help guide you through it. Otherwise, you'll end up, dropping $600 on custom orthotics. So I'm happy to kind of point that stuff out. And a lot of times I can kind of make the correct suggestions so that you're not kind of trying to Google stuff into the dark. I can kind of help guide you on what's going to work so you don't get to that point, right? And I think I don't know if I ever operate on somebody for a bunion the first time I've met them. It's very rare that somebody comes to me having done all the right things, beforehand. And the reality is I will never, ever tell somebody they need bunion surgery. Nobody needs bunion surgery, right? It's not an infection. It's not a fracture. It's if your pain is bad enough and it bothers you enough on a daily basis that you want to consider undergoing what's, can be a pretty significant surgery, then it's a reasonable option to consider only after you've tried all the other reasonable things that aren't surgery first. Because you can get infections, your bones can't heal together sometimes. Surgery is not 100%, right? Like the best surgeries we do are still 95% satisfaction rate, which sounds, if I say 90% satisfaction rate, you're like, oh, that sounds great. Well, when I say, 1 in 10 people aren't happy they did it, it sounds not so good, right?
Mm-hmm.
So, that's kind of the point is, hey, come to me before you get to that point where you feel like you've got nothing left and we can figure some stuff out. But if you get to that point where it's just like, all right, I'm sick of this, I get it that, surgery is painful and stinks, and all that stuff, then I think that's kind of the time when you consider kind of undergoing that surgery.
What are the most common surgeries that you do?
I do such a wide variety of surgery that it's almost hard for me to pinpoint what the most common thing I do is. It's one of the reasons I love foot and ankle. I'll do 6, 7, 8 surgeries in a week, and sometimes I won't do the same thing twice. I think probably some of the most common things I end up seeing are ankle instability and kind of reconstructions for that when your ankle kind of just keeps giving out on you after you sprain it. A lot of Achilles tendon stuff, so we call the pump bump or the Haglund's deformity, kind of people who can't wear any shoes and have constant pain in the back of their heel. And then a fair bit of trauma and arthritis, so lots of fractures and things like that.
So for ankle mobility, how much, or is it an issue if you're overweight? Is that putting a different kind of stress on your ankle, and then even going through the process of losing weight? Because for me, I've lost over 100 pounds and I feel like from where I was before and how my body was structured, used to holding that weight through the process of losing the weight, and where I am now, it kind of feels like I kind of put everything through the ringer.
Yeah. And the losing weight will always make all these problems easier, right? So, you're talking about putting force to your foot. Well, the force you're putting through your foot is your body weight. And it's the same thing they'll talk about with knee arthritis. With every pound that you lose, that's 4 to 6 pounds off your knee in terms of force. So there's like a multiplicative effect. Even modest weight loss, right? Like you lost 100 pounds, which is freaking amazing. Congratulations.
Oh, thank you.
But, even if you're just like, not able to have that kind of dedication and thing, even a 20-pound weight loss, that's 100 pounds off your knee, off your foot. So even modest weight loss and some smaller changes, can really help you do that. And then once you start having less pain, you can even be more active. And then it kind of the process kind of snowballs on itself in a positive way.
But is any of that affecting ankle mobility at all? Of thinking of like, that's kind of what's kind of holding you and you're moving on?
It can affect it. I wouldn't say it affects mobility so much as it can affect structure. So I definitely see more arch collapse, things like that in people that are carrying more weight on them.
So what's like the biggest piece of advice that you give to people that come in and, have issues with their feet and ankles where you're like, kind of incorporate this into everyday life of taking good care of your feet and ankles because, we live on them.
Yeah. And at the risk of sounding like a broken record, but I think it's important enough to kind of really reiterate it, is absolutely stretching out the heel cords. I think that causes so many problems. And that's like, I know everybody thinks that their thing's the most important. If I could have my patients just do one thing every day, it would be to just keep those heel cords stretched. I promise you, it'll just save you so many problems.
And that's just like toes on the top of a step and leaning back? Oh,
yeah. Hanging your heels off the top of a step, kind of leaning against a wall. Heck, Google heel cord stretches and do something. Whatever, anything's better than nothing. But I really think that helps with so many problems.
That's awesome. Well, thank you so much for your time. I'm gonna have to start incorporating those stretches because I'm bad at stretching, man. So it's like
I'll send you my handout. It's fine.
What'd you say?
I'll send you my handout.
Yes. Well, yeah, that's why I don't want any sort of foot surgery. So that's why I got the Hokas. I'm trying to take good care of my feet. And, I think that's where it's like, okay, well, if we can do a stretch and we can figure this out so we don't have to have any sort of surgery, obviously that's the best avenue to go. But if somebody is having some sort of pain and, can they just come see you and get a checkup? Can they specifically request you at Christ?
Oh, absolutely. Yeah. And the rule is I always say yes. So I will always fit people in, all that kind of stuff. Drives my staff nuts because, we'll be double booked. They'll be like, oh, can you see that? Yep. I'm fairly certain that when I'm in a patient room, they get those calls. They go, oh, no, he's too busy. But when I'm out there, yeah, I'm always happy to see anyone. And like I said, just because I'm a surgeon doesn't mean that I operate on everyone. I would say I operate on the minority by far of the patients that I end up seeing. And I'll joke with my staff, I do a lot more surgery if I was worse at getting people better without it.
Yeah. And I think that's important too, because I know for me, I had to see an orthopedist for my knee, which I do have arthritis in. And my fear was I don't want to go because I'm going to be talked into surgery and I don't want surgery. And when I went, it was none of that. It was like, no, we can work on strengthening the muscles and stretching the muscles and let's get you in physical therapy. And I think that there's just so much fear around seeing a doctor or going to a hospital of like, oh, they're going to make me do this thing, when in actuality, it's like, no, how can we get you healthy in the best way possible that's easy so we don't need to put you out?
Absolutely. I think the worst thing any surgeon can do, and now there's exceptions to this, right? Like there's certain things, typically trauma, sometimes nerve compression, where I know that this is going to get worse without surgery and it's going to get worse in a way that I can't fix it. Right. Mm-hmm. So if you break your ankle and dislocate it, like you got to have surgery on that. Right. And I'm like, look, if you're my mom, this is what you need, but for stuff, especially chronic problems, like things like that, a little fallen arch or a bunion or midfoot stuff, I think that falls into what we call elective surgery, meaning that the patient elects to do it. Mm-hmm. Right. And the worst thing any surgeon can do, and I'm very careful to really never do, is I don't ever want to talk somebody into elective surgery. Because nothing is perfect. I could do a perfect surgery and things can still go horribly wrong, right? There's an infection rate for a reason. And it's less than 1% in my patients, but it still happens. And guess what? I get to see those patients, every week while they're kind of getting through this and, take care of that stuff. And if you talk someone into surgery and then it goes badly, that's just the worst,
Yeah.
So I don't ever talk anybody into surgery. And in fact, what I usually say is that if I can't talk you out of surgery, that's probably when it's time to have surgery.
Yeah, that's awesome. Well, Dr. Kulwin, thank you so much for your time. I know you're very busy and you're double booked with patients, so I want to let you get back to looking at feet.
All right, I will get right back to that. It was a pleasure to meet you and pleasure to chat.
Yes, thank you so much.
For info on health coaching and more, go to AmandaValentineBites.com.